Griffith-Jones, who will be providing technical support during the session. So over the past year, there was a lot of focus, obviously, on responding to the pandemic. And, oh, sorry, Lynette told me to tell you that we are recording this session. So please make sure to mute your mics and turn off your videos until the discussion that we will have in the end. Apologies for that. So yeah, there was a lot of focus on the pandemic, but at the same time, it was important, as we heard also during our introductory session with the keynote speakers, not to lose sight of other essential health services that still had to continue. And in addition to that, some of the measures that were taken due to COVID had a negative effect on other health conditions. So in this session this morning, we would like to reflect on the past 12 months, looking at how health partnerships continued their work and both continuing on the initial focus that they were having before the pandemic, and also how they responded to the new pandemic situation. And most importantly, how their work potentially contributed to more resilient health systems after the pandemic. So I'm looking forward to three presentations on a range of topics. We will be covering antimicrobial resistance and infection prevention control. We will hear about mental health services and also anesthesia training in a pandemic situation. Before we move to the presentations, we would like to get an idea of who's in the room. So we will have a very short poll to get to know the audience better. We would like to know from you whether you're currently involved in an institutional health partnership. So this can be a South-South partnership or a North-South partnership. So you should see that in the chat, and please go ahead and respond now. Lynette, are you getting the answers?
Yes, we've got 83% voting at the moment.
So I'll give you a few more seconds to respond. So Lynette, do you want to share the results? Okay, so we have most participants from the Global North and many who are not yet in a global health partnership. Okay, that's great. Thank you very much for your participation. So we will have three presentations, and after each presentation, we will only have a very brief opportunity, really only for questions for clarification, but don't worry, we will have time for discussion after the three presentations. We have Greg Harrison from the Gulu-Sheffield Mental Health Partnership, who will be the rapporteur of our session. So he will be part of the panel discussion after this breakout session. We have 5 presenters today. The first two will be Fiona Rees. She's a highly specialized pharmacist from Brighton and Sussex University Hospitals, and Chitunda Mbao. He's a hospital pharmacist at Ndola Teaching Hospital in Ndola in Zambia. We then have Opio Nicholas, who is a partnership development worker at Gulu-Sheffield Mental Health Partnership, and Alfred Roti. He's a senior psychiatric clinical officer at the Gulu Regional Referral Hospital. And then we have Anita Sugavanam, a consultant anesthetist at Brighton and Sussex University Hospital. And she's also the director of the Brighton Zambia Anesthesia Partnership. So I see that about half of the people in the audience are part of a partnership at the moment.
I can hear you telling me details of your patient. You want to go on mute.
So before we move to our first presentation, I would still like to ask one more question to the audience. So for those of you who are in a partnership, we would like to know whether you have been able to continue working within your partnership over the past 12 months during the pandemic. And I hope you can see the question on the screen. And for those who are not in our partnership, you can check not applicable. Okay, do we have any results yet? Okay, so there's a lot of change in focus of the partnerships and less than planned, and only 3% were able to really continue as planned, and 3 not at all. Excellent, thank you very much. Okay, let us now move on to the first presentation by Fiona Rees and Chitondu Mbao. This is from the Brighton-Lusaka Pharmacy Initiative, which was established in 2016. The partnership links the University Teaching Hospital Lusaka with the University of Sussex Brighton and Sussex Medical School. And the partnership has focused on antimicrobial stewardship and has been championing pharmacists as antibiotic guardians in Zambia. And most recently, they have been focusing on enhancing infection and prevention control through capacity building and locally producing alcohol-based hand rub. Fiona and Mbao, over to you, please.
Thank you very much. Can everyone hear me?
Yes, we can hear you, Fiona.
Lovely, thank you. My name's Fiona, as they said, and I just want to say thank you for inviting us to speak about our experiences about health system strengthening in the Brighton-Lusaka Health Link. We've been asked today to talk about how our partnership has been able to continue working on and provided training that was not directly COVID-19 related, but instead contributing to health system strengthening. And also, would this then lead to better pandemic preparedness in the future? And if this has led to greater use of in-country expertise? Now, we're going to come to the first 2 points throughout the presentation, but I just wanted to highlight that I think the fact that we have a senior pharmacist from a different hospital, my co-presenter Mbao from Ndola Teaching Hospital, is joining me to co-present here, shows that not only is there greater in-country expertise, but also the inter-country networks and working collaborations have successfully been solidified throughout our processes and projects this year. I just wanted to briefly show that throughout the Brighton-Lusaka link, we are aiming to ensure that all of our activities comply with the WHO AMR competency framework to ensure that there is health system strengthening at the core of everything. I'm now going to hand you over to my co-presenter Mbao, who's going to talk about our efforts and outcomes with regards to infection prevention and control.
Thank you, Fiona. As introduced, I'm Chitondu Mbao, senior pharmacist at Ndola Teaching Hospital in Zambia, and we've been working with Lusaka Brighton Link project in terms of infection prevention. So just a brief background, Ndola team a long time ago partnered with Guys and St. Thomas in 2012, and through that we've been able to accumulate surmountable knowledge through trainings and also partnership. So we were incorporated in order to help train the UTH staff in the principles of infection prevention, and that included bare below elbows, hand washing, and rubbing also. And we conducted a training at UTH, and we managed to train 30 staff from multidisciplinary teams, which included nurses, included doctors, pharmacists, and also environmental health personnel, and also cleaners. So technically, the training took 1 week, and we trained them in those principles. Next slide, Fiona. After the training was done, the training actually took 1 week. We and the UTH team now, who we had trained to be champions, IPC champions, that is in infection prevention, went on and trained other 3 hospitals using the Third Healthcare Worker Action Fund. We trained 3 teaching hospitals, which included Kitwe Teaching Hospital, Livingstone General, and Levi Mwanawasa University Teaching Hospital. So in total, we trained 180 multidisciplinary healthcare workers, which included doctors, nurses, environmental health pharmacists, and also other healthcare workers that were technically involved. So these were trained also to be champions in their institutions in order to spread the infection prevention techniques to other healthcare workers. Next. So after trainings, we discovered that job aids were lacking in these facilities. We didn't have anything to show that health workers can rely on as they are working, especially near alcohol-based hand rub warm-ups. So working with the partnership, we managed to do posters which were basically appropriate to our environment. And as you can see from this poster, it talks about healthcare, infection prevention techniques like bare, below elbow, and technically how to hand gel and hand rub. Next, please. From there on, in order to champion infection prevention, using partial funds from the Commonwealth Partnership for Antimicrobial Stewardship, we managed to provide or buy a distiller for the University Teaching Hospital and the starter pack equipments for them to start producing the alcohol-based hand rub. We also trained the staff in the pharmacy in the production process using the WHO modified formula for hand rub. And from there on, they managed to be producing 40 liters every day. And now, during the pandemic, they've increased to 120 liters per day due to demand. And again, the UTH and DOLA team combined using the Healthcare Work Action Fund and was able to expand these trainings and provision of the starter pack equipments to the 3 hospitals that were trained in infection prevention techniques. And therefore, we've seen up from that time up to now that these hospitals have been able to produce their own hand rub, as I shall show you later. We further on produced videos to showcase hand hygiene and hand rubbing techniques, and also infection prevention and how to manufacture hand rub. And we posted these videos on the Commonwealth Pharmacists Association and also on YouTube. And through that, we've been able to see the Brighton Sussex University hospitals adopting what we had put in, and they are now producing hand rub based on those kind of media that we had put forward. Next slide. After training all these facilities in hand rub production and infection prevention technique, we further saw a need in order to go a bit further and technically provide a standard operating procedure that we can distribute in these hospitals so that healthcare worker can look at them and follow and also help them in their day-to-day work. And therefore, with the partnership and the LINK project, we were able to design and basically produce a very good standard operating procedure for hand hygiene and also hand rub production, which is in the process of printing at the moment. Next slide. So from the expansion of the program, we can see that from the time we started, only in Ndola Teaching Hospital in 2014, because they were trained earlier, we are producing the hand wrap. At the moment, in 2019, 2020, and 21, we trained other hospitals, and we can see the quantities that we've produced up to now, especially during the pandemic. The production has actually increased. We've produced a total of about 14,500 liters against what we demand, which is about 15,000 liters as a unit in total for these hospitals that are producing. So the program has been sustainable from now, and with the coming of the partnership, it has actually expanded to other hospitals, which is a good thing. Next. So the factors that have led to sustainability technically include quality. So we've been able to assure quality of this hand wrap that is being produced. For example, when Ndola Teaching Hospital started producing in 2015, it was a requirement that we send samples to WHO for testing. So the samples were sent and were tested by WHO, and surprising enough, we were told that actually Zambia was the first country to have sent samples and passed the quality controls on first attempt in that time. And therefore, we've been able to assure that what we are producing is of quality. Next. We've also been able to expand knowledge. As you saw, we've taught a lot of hospitals now, and we continue teaching other hospitals. Currently, we are in talks with the ministry trying to secure some funds to expand the hand wrap production in other hospitals that we've left. And we've seen a sustainability process because of this spread in knowledge. Next. Okay, the other factor is that people have been able to accept the commodity that we are making in these hospitals, and therefore they've embraced it and welcomed it, and therefore that acceptability has technically generated a demand in these hospitals, and therefore we are proud.
1 more minute. Sorry, 1 more minute.
Okay, thank you. Next. Okay, so availability also, we've been able to increase availability, and we've seen support from other facilities. Fiona, you can take it up.
Thank you, Mbao. I just wanted to quickly say that on top of those amazing achievements, also what's happened within Lusaka is there's been an antimicrobial stewardship pharmacist, which has been working with the multidisciplinary team, which has been looking at things like guideline developing and monitoring and evaluation. As part of that project as well, the multidisciplinary team, which also included input from other hospitals and the University of Zambia, have set up an antimicrobial stewardship training pack, which is available for use all over Zambia and is currently going through accreditation so it can be approved nationally for official CPD records, and that it could be shared and actually implemented into the national guidance. And finally, audit and monitoring evaluation is seen as paramount to ensuring that the project is achieving its targets, but also developing and highlighting places where it needs to improve. But the team didn't feel like they actually had the skills to do this. So again, another country collaboration was set up between Zambia and Ethiopia, and audit and monitoring and evaluation training was done. And it was the first time this had been done online between these two countries. It was 1 week, done remotely, and they were able to get accredited and certified for this for future projects. And this just looks quickly at the overall review of how we think that all of these projects have actually helped with health system strengthening, pandemic preparedness, and greater in-country expertise. We hope you found that useful, and thank you for your attention, and happy to answer any questions at the end. Thank you.
Thank you very much to both of you. That was a great presentation. Thank you. And yes, we see already a few comments in the chat. Are there any quick questions for clarification? If not, then we will move on to our next presentation. So let's see if Opio and Alfred, can we hear you now? Can you just, fantastic, okay. Excellent. So we will have a presentation from the Gulu-Sheffield Mental Health Partnership, which was founded in 2012. The partnership links the Gulu Regional Referral Hospital in Northern Uganda with the Sheffield Health and Social Care NHS Foundation Trust. And the partnership has a focus on patient and service user safety. And they have been working on suicide prevention and have been able to continue their work throughout the pandemic. And I look forward to hearing their presentation on their work over the past 12 months. Over to you.
Can you just take the next slide? Yes, can you? Hello?
Yeah, please go ahead. Thanks.
Okay. Thank you, everybody. Warm greetings from Uganda. At the interest of time, we are looking to tell you that we just make a big slide or expand on, but I'm here to give some bit of explanation. Uganda is a landlocked country based in East Africa with a population of 4.27 million. This is according to 2019 statistics, with the land size almost the size of the UK. Uganda registered the first case of COVID-19 on 21st March 2020, and since then, cases continue to increase slowly. The government has put in place strict measures to contain the COVID-19 outbreak in Uganda at every population level. Today, confirmed cases of COVID-19 in Uganda stand at 40,501. And the total of about 6,099 recovered. Then there are also about 334 cases of death. This is a figure which we came up with on Wednesday. We were able to update it. But the rate of vaccination appears now being increased. By Wednesday, we had one.
So, sorry to interrupt you. We're still having trouble hearing you. Is there a possibility that you can speak closer to your microphone?
Oh, yes.
You're fading out.
Yeah, today Gulu Regional Referral Hospital located in northern Uganda, 336 kilometers away from capital Kampala, registered 209 cases of COVID-19. These are patients who had very severe illness.
I'm really sorry that I have to interrupt you, but it's extremely difficult to hear you.
Hello? Can you hear me?
I can still, I'm having trouble hearing you.
Hello?
Could we suggest they turn their camera off to see if that helps reception?
Yeah. Yeah.
Okay, yeah, try again. I'm really sorry. It's very difficult to hear you. Lynette, may I suggest that we listen to the recording by Anita first, and in the meantime we try and find a solution for this one?
Yes, of course.
I apologize, Ophir and Alfred. I'm really sorry, but we would really like to hear your presentation. So we will switch to our planned third presentation now, which will be a recording because Anita is on duty at the moment. So this is from the Brighton Lusaka Health Link, and this partnership aims to empower Zambian and UK-based healthcare professionals share clinical skills and knowledge with the goal of improving health in Zambia and in the UK. And the main focus of the partnership is advocacy for non-physician anesthetists, bringing all anesthesia providers together, promoting career progression and quality improvement. So we will listen to her. Are you here, Anita? Sorry. Even better.
So yes, I am here, Dota, but I'm actually sort of sneaking in and out. So basically, yeah, if there's a question, I'll hopefully be able to answer it.
Okay, great to have you.
Thank you. I think my colleague Sophie will also be joining, so she might be able to stay for a little bit longer, but let's see how we go.
Fantastic. Go ahead.
So I can't hear the pre-recorded session, and I'm going to have to leave in a minute anyway. Is it worth trying it from the beginning again? I'm not sure if anybody else can hear it.
No, I wasn't able to hear it.
No.
Lynette, are you there?
Sorry, is it working now? Sorry, could anyone hear that, or am I? No. Sorry. I thought I'd set this up properly. Sorry. Let me try again now. Sorry.
I am a consultant anaesthetist. Good morning, everyone. My name is Anita Sugavan, and I am a consultant anaesthetist in Brighton. Myself and my colleague, Dr. Sophie Morris, are the co-directors of. Is it possible to make the slides bigger, or is that just my screen?
Sorry, that's the full slide we have.
Okay, no worries.
Is it audible now?
Breakout, Brighton Zambia Anesthesia Partnership. So I'd like to thank the organisers of the course for inviting us to speak today about the experience we've had with our partnership during COVID-19. And the question I've been asked to answer is whether I think the activities conducted in the last year will contribute to better pandemic preparedness and response in the future. So I apologise, this is pre-recorded, but I hope to make the Q&A session live a little bit later on. So I'll just crack on. Let's just... Right, so a little bit about our partnership. We are partners with the Zambian Ministry of Health, the Society of Anesthesia in Zambia, which is mainly physician anaesthetists, Levi Mwanza University, which houses the School of Anesthesia, and then finally us, Brighton and Sussex University Hospitals, and the Brighton Lusaka Health Link charity. Our focus is mainly on non-physician anaesthesia providers, and over the last 5 to 6 years, what we've really tried to hone in on is helping them with career progression and the provision of a BSc, uniting physician and non-physician anaesthesia providers, as it's very much been separate paths since their inception. And we run sort of update and training workshops in Zambia a couple of times a year usually. We were really pleased because in 2019 we were awarded a SET UK grant to oversee 20 quality improvement projects across the country, so not just in the capital. And each QI team consisted of a UK volunteer, a non-physician anaesthesia provider, and then usually another Zambian physician. We were really excited about this. We got round to allocating teams and projects, and even had a couple of site visits both in Zambia and in the UK, but had to suspend all activity leading up to the first wave of COVID in the UK. And obviously, and during that first wave, the UK faculty were completely out of action. We were obviously experiencing what everybody else knows as the phenomenal learning and task sharing and upskilling. And with that came a lot of stress and burnout. And things were very quiet with Zambia. And then sort of towards the end of the summer, we, as we were coming out of our first wave, we got back in contact and really started brainstorming about what to do. Zambia at this point hadn't had a big first wave, and in fact had very little experience of COVID-19. And there were big concerns about another wave and their COVID preparedness. And to quote one of our Zambian colleagues, I don't even know what we need to know. So there was a little bit of panic, and we thought we could help each other out. One thing Sophie and I knew was that we couldn't really ask our UK faculty to do very much because of the situation. So we were very careful not to promise things we couldn't deliver
Hey,
on.
Safi,
We made it very clear that obviously we couldn't visit, we couldn't really oversee any kind of workshop or training, even if it was virtually, weren't even sure.
It depends on the hello, I would say.
We were very keen to share our experience virtually. We designed with our Zambian partners a 3-day course, and it ended up being organised really nicely because the Ministry of Health took over ensuring attendance, providing lifebox pulse sensors and PPE so that participants could take that back to their home hospitals, which is very important in COVID management, and of course things like venue and logistics. The main faculty were provided by the Society of Anaesthesia, so physician anaesthetists, and then we were basically called in to facilitate COVID-specific sessions, either live or pre-recorded over Zoom. And it worked. We managed to deliver 2 3-day courses, a total of 54 participants, all of whom were non-physician anaesthesia providers. This was held in Kabwe, which was one of the COVID-19 centres. And given the time that we organised this in, it's actually incredible what we've pulled together. Just goes to show, very much like the COVID response in the UK, that when the pressure's on, you can actually get a lot done. This is an example of one of the timetables. This is, I think, the day 1 of the course. And just to show you, there's a mixture of UK and Zambia faculty, us coming in over Zoom where possible, but things like an overview of COVID, infection prevention and control, triaging patients with COVID, screening and testing, operating theatre pathways, and then breakout groups, including doffing and donning PPE. So really, I think I'll start off with comments and feedback from the UK side. I think one thing that was a real step of progress was that we were far less involved this time round in our activities in the partnership. the UK side is often heavily involved in the design and development and execution. And actually, because of COVID-19, we were just slotting in where we were needed and requested, and it was very much locally run, which is how we want our partnership to run. So that was almost a silver lining. We also reached out to other specialities and other hospitals within the UK for faculty. So prior to this, BrightZap consisted almost entirely of consultant anaesthetists in Brighton and a few in Worthing. But we had our microbiologists in the end deliver lectures, to give you an example. So we broadened our, if you like, our faculty over this side. And the Society of Anaesthesia in Zambia, the physician anaesthetists, learned very quickly from the first course and actually ran quite a few sessions on their own in the second course. Again, I'm not sure if that would have happened in a non-COVID situation. And we were sort of dreading how Zoom would work and what the technology was going to be like, but actually it worked very well. The connection was good. The only thing I'd say is facilitating practical breakout sessions is a little bit tricky when you're a face on a computer screen, but we did manage. Really useful learning for pandemics from the Zambian side were the learning around escalation of oxygen therapy and the use of lateral and proning positions, so patient positioning. The use of screening questionnaires in the absence of a widespread testing situation. The nuances of things like cardiac arrest and anaesthetic emergencies with COVID-19. General improvement in ventilation strategies for critical care. And then obviously familiarity with the PPE and how to put it on and take it off safely, as well as the use of pulse oximeters, which each participant could take back with them. Again, very useful in COVID-19 triaging. What came through was that rather alarmingly, there was a complete lack of anaesthesia involvement in local and national COVID-19 task forces, and that needed to change. Crucial things like oxygen, PPE, and ITU equipment needed addressing. Decentralization was another issue, so how to get the learning out from centres like Lusaka and Kabwe to the rural areas, and the same for screening and testing. And then I think unexpected learning for Zambia was the fact that there was a whole piece around developing surgical pathways around COVID-19 patients and rearranging the operating suite for that. So going back to the question, do I think activities conducted in the last year will contribute to better pandemic preparedness and response in the future? Yeah, I think our workshops really have made a difference. I think going forward, our Zambian partners are going to be far more proactive in making sure there's anaesthesia presence in the pandemic response. Whilst the call for critical care capacity has always been there, I think what we managed to achieve with this course is understanding what can be done without critical care capacity. So in the UK, a lot of effort obviously has been diverted to preventing patients entering critical care and avoiding patients getting intubated and ventilated. And our strategies with oxygen therapy and patient positioning, I think, were really important to show our Zambian colleagues that actually you can look after many of these patients without the fancy equipment and complicated monitoring. I think going forward, prompt virtual shared learning with partners is always going to be and so repeating this kind of activity I think will be really successful. And I think our Zambian partners have been thinking now quite hardly about the response regarding intensive care capacity, but also how to organise surgical pathways, emergency surgical pathways for patients who may or may not have COVID. And that's a separate piece that's going on at the moment. A course is being put together for that and a think tank. But of course, we always have to remember that this is all hindered by lack of funding when it comes to staff, drugs, and equipment, and we've seen that here in the UK too. So it's shared challenges really. And really, that's all I wanted to say. So I'm happy to take any questions in the break time, and I hope you found that very useful. So thank you very much.
Great, thank you. Thank you for this. How are we doing with the presentation from Opio Nicholas and Alfred Droty? Do you want to give it another try? Can we hear you now?
Are you going to hear us?
Yes.
Hello?
Yes. You seem to be.
You're going to hear us?
Yeah. Go ahead.
So can we go on with the presentation?
Please do, yes.
Yes, I think I'm just going to start afresh with somehow between. Are you able to hear me? Hello? Yes,
I'm really sorry. I'm really sorry. You're still breaking up. As a backup, is it okay for you that Kim Parker, who's on your team, presents? She just received your presentation and she will be happy to jump in. And just because we're really having a hard time hearing you, if that's okay with you. And Kim, are you ready?
Yes, I was just wondering if I could try to get them on the telephone and see if we can try it that way. Do we have time to try?
We don't have a lot of time, but it would be really good to have them.
Yeah, definitely.
Please do. I'm not sure if that's going to work though, but
let's try.
For people in the audience, I hope it's okay with you for the discussion that we go a little bit over time. So we really have time also to have a discussion after these presentations. Do you want to still start with the presentation though?
Yeah, if you could pop this, if it can be put up onto the screen.
Lynette, can you put the presentation on the screen?
Okay, Alfred and Nicholas, I'm really sorry. I'm not going to be able to give this the justice that you could. I don't know if you can access the chat function and maybe you can comment in the chat. Can you see the chat function? Okay, so this is partnership in the time of COVID from the Gulu Sheffield Mental Health Partnership. The partnership has been working since 2012, and we've worked on a number of patient safety projects. This first slide is just an introduction to Uganda. You can read what's on there. It's a population of more than 44,000 people. Land size larger than the UK, slightly less than UK, which is something I didn't know. Uganda registered the first case last March. And although the numbers are relatively low in comparison, they have slowly started to increase. As you can see, I can't see all of this, sorry. There have been only 334 deaths, which is very good. So that shows that something has been working and something's been going very well. Vaccination started there on the 10th, I believe, and they have so far vaccinated 1,215 people, which is amazing. The hospital had a COVID-19 treatment centre for those who were very poorly, and 279 people have been in there. Those on home-based care are 41, and the actual hospitals had only 6 deaths. Just to give context, Gulu is on the border of South Sudan, so takes patients from the whole of the north and from South Sudan. Okay, next slide, please. Over the last 18 months, the partnership has been working on suicide prevention and awareness, which was that funded project. Because we weren't able to go out and we weren't able to manage the work in the way we had intended, we had to scale back certain areas. We did have an underspend, and we were able to use that underspend to provide some COVID training for the staff on the mental health and psychosocial aspects that COVID was bringing around. This was primarily aimed at health staff in the hospitals because that's where at the time the main focus was. Next slide, please. So what we did was we were able to access training that the hospital staff had already taken part in from UNICEF and Breakout Hospital. They did some trainer of trainers training, but unfortunately there wasn't any ongoing money to any budget to sustain that and keep that going out into the health centres. So we were able to go out into the health centres in the Gulu district on the same package of training that UNICEF and Breakout had rolled out. Health workers are the first line responders and in contact with people in the community. So they were the target for this work, and that was done between October and November last year. Based on that work, we were able to apply again to THET for a grant through the COVID-19 response. And we are very proud to be able to say that we have some work starting on the 1st of November to train another 180 health workers out in the community. Next slide, please. So lessons learned from the mental health and psychosocial support training is something that I'm going to really struggle to be able to provide, because this is what they uniquely would have been able to talk about. Nicholas, Alfred, are you able to put anything at all into the chat?
I think so. We'll try that.
Yeah, please try.
I would like to.
I think a lesson that has been learned was that staff need support in an area that is a new emerging infection. It's very scary for everyone. Gulu Regional Referral Hospital have a lot of expertise in infection control and manage very successfully Ebola outbreaks in the past. And on the most recent Ebola outbreak, they were called on from the hospital. So they do have a lot of expertise there, but they were very quickly overwhelmed with the number of people that were needing to be isolated in the very small isolation unit there. So a relatively basic level of training, but also bringing in how to help people emotionally when they are having to care for people in a way that they may not have had to do before, with an unknown infection that was around the world. That was really important, that the emotional and psychological aspect was attended to. Is there anything from you guys? You able to contribute anything?
Thank you so much, Kim. Thank you for taking over so spontaneously.
Is that the last slide? Oh, there's one more. Okay, so this final slide really is about the bulk of the work and the connection between COVID and suicide. Because of the lockdown in Uganda was very severe, and there were nighttime curfews and they were very harshly dealt with. People were not able to go out and find work. People with mental health problems weren't able to go and seek treatment or get support. And there was an increase in suicide during the last year in Gulu. Throughout the pandemic, we've been able to train health workers, community leaders, and some journalists who all have an impact on how suicide is referenced and managed. And there has been an integrated link between suicide and COVID. And we were very grateful to be able to use that money to provide COVID training, and the fact that we're going to be able to start in just 2 weeks to carry on. I really haven't done that justice, and it's such a shame that Nicholas and Alfred, who've put this presentation together and worked really hard, haven't been able to join today. But thank you to them for putting this together and for doing such an amazing job.
Yes, thank you very much. Thank you, Kim, for jumping in so spontaneously. Thank you very much to Opio, Nicholas, and Alfred Roti for this presentation. I'm really sorry that you weren't able to provide it yourself. I think there are amazing lessons to be learned also in relation to the short extraction from the film that we saw earlier this morning. I think there are really lessons to be learned both in Africa and in European countries. Thank you so much. We now open the floor to discussion. So as I said before, if okay with you, we will go a little bit over time to have a discussion following these 3 presentations. So I'm opening the floor. I haven't seen any questions in the chat yet, but please feel free to open your mic and ask any questions that you would like to ask. No questions so far. So I would actually be curious about the last presentation, and maybe Opio and Alfred, you're able to respond to that. Have you been able to, have you seen any mutual learnings, or really learning from what you experience? And as you said in your presentation, you already have so much experience with pandemics, so with epidemics, I'm sorry. So has there been any spillover to learning in the UK within your partnership? Would you be, can we hear you?
I think in the UK we were very quickly overwhelmed. Back at this time last year, we were going into lockdown, starting to get into a bit of a frenzy at government level. And I think in Gulu they just quietly got on with it, because it was, you know, they have that expertise, they have that prior knowledge of working in this way. I think that's the biggest learning for me, is to just they were able to just get on with it.
Yes, you have very severe signal problem. To respond at the moment.
Can't think of anything else to add, sorry.
Yeah, okay, thank you very much. Okay, are there any other questions from the audience about any of the 3 presentations, not only the last one? We have Anita back, so she will also be able to respond to your questions. And of course, we have Fiona and Mbao, who are also here to respond to your questions.
Yes, this is Anne from Solidarmed. I was really interested in the first presentation about IPC, because we are currently starting a project on IPC in Mozambique. And it is quite well, just a technical question. You mentioned that you, at some point on your slide, there was like knowledge outside. And, you know, I think, would it be possible to get access to the SOPs that you've developed and to see if we can adapt them for in the Mozambican context?
Hi, Anne. Yes, our team's very keen to share all of our work. So it's not just my work, though, it's collaborative. So I saw your question, and I have actually asked that question to the group, and I'm sure they will be happy to share, and then we can do that. So if you want to put your email in the chat or something, and then we can send on as long as they're happy. It's just going through accreditation at the moment, so it might have to wait until after that point.
Yeah, but anyway, to share experience also, it would be interesting.
Absolutely, it'd be great to have networks. Brilliant.
Okay, thanks.
I have a question for you. This is Judith, I'm the chair of THET. So this is just a general question. The presentations were absolutely great. One of the things we're debating is COVID has changed our view on the use of online learning. And the Pulse today and the launch of Pulse and trying to share things through Pulse is obviously some way we're trying to address this. But it was just a question to everybody. We've got about climate change too. I think it's vital to have that face-to-face relationship, to have the trust to then engage in online learning, because we're moving more and more to online because of things like COVID and travel restrictions. So it's just a question really to all the partnerships, a learning lesson from COVID.
I can have a go at answering that first, if that's okay. So just from our experience with the anesthesia partnership, and also not to forget what's happened within our own system here, where virtual teaching and meetings have exploded. I think the answer is that we're very grateful for what virtual learning has enabled, and the course we delivered wouldn't have been able to think of that, a year ago. But I completely agree that there is a unique place and value in face-to-face. In general, maybe conferences in the future will change to having big virtual components, but I think the value of face-to-face is second to none. And there's a lot of practical teaching involved in what we do, so that's quite difficult. And I just think connection, I think there's something lost with partnerships if it's purely virtual. And as we've seen in this forum, the technical glitches are, if anything, just get annoying, don't they? They just get in the way. So I'd like to think going forward that yes, we're going to do more things virtually. Yes, we're going to reduce our carbon footprints by not traveling all the time to places where we teach and share. But I'd be very sad to see face-to-face removed completely.
Can I echo that? I think it is, and this last year has proven that it is entirely possible to continue excellent work without having to have that face-to-face, but it changes and it's different. And I think with an existing relationship, that makes it so much more easier. I can't begin to imagine what it would have been like if there hadn't been that existing relationship there. In the field of mental health, because a lot of the issues that we deal with are around stigma, and the stigma of having COVID, and the stigma of living with COVID, the stigma of being a COVID worker. Challenging all of that is a lot easier, and working with that if there's an existing relationship. So absolutely, I hope we won't ever lose face-to-face contacts, but remote is entirely possible, entirely possible.
Great, thank you very much. Mbao or Fiona, did you want to comment on that question?
Just from our point of view, we've been doing a lot of remote learning and meetings and things throughout the whole partnership, really. And especially it was useful between Lusaka and Ndola as well. But again, I agree that if you didn't have those relationships and those connections to be able to strengthen those meetings, it might have been more difficult. So I think there's got to be a kind of combination of both remote or online learning, but also that face-to-face.
Great, thank you so much. Is there any other question? Maybe as a follow-up, maybe you want to comment on any cultural challenges, if there were any, in this not only related to the new way of working together, but also regarding the topic of mental health and how the partnerships worked with that. Were there any cultural challenges? Kim, I think you were saying something. Sorry, Kim, were you saying something? Okay, I don't seem to hear her. Sorry. Did anybody want to respond to the question about cultural challenges?
I have an interesting comment from the other side. Many of the partnerships have worked remotely throughout. Obviously, you can't just pop to Lusaka for a monthly meeting. So prior to the pandemic, the volunteers involved with the partnership scheme were very used to this way of working. And an interesting reflection is when the COVID pandemic hit the National Health Service in England, where I work, the volunteers were actually much better able to cope with the technology than many others. When all the meetings suddenly went online, presentations and all the rest of it, there were lots of people who found that really difficult. But because this was a way of working that we've all been used to, it was easier. And I think I agree with Fiona and the others. The face-to-face actual real meetings make it much easier when you're moving forwards. The work with the hand sanitizer video that Fiona and her team did with Mbao in Dola was done so fast when it was really needed. And that was as a result that the relationships had already been built. So we could just get on with it and get it done, get it used, protect health workers. So I think the partnership model really, really works. And in some ways, the fact that everybody's now doing online meetings is possibly bringing us closer together in some ways. I mean, look at the participants in this conference. I mean, we wouldn't have had that many if it had been in London. So I think there are some positives to take from it. Thank you.
Excellent. Thank you very much, Sarah. I think on this positive note, we will close this meeting. Apologize to everybody for the technical challenges. I hope you still enjoyed the presentations. From my side, I did. Thank you for everybody. Thank you to all the speakers, and thank you for everybody's patience. And maybe see some of you in the afternoon session. Thank you. Bye-bye.
Thank you. Bye.
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 Bye-bye.